Are you queuing us in? Okay, great. All right, well, we are prompt. It looks like we have a handful of people coming on. Almost certainly additional people will be coming and joining us, and we are recording this. So welcome everyone, and welcome to our speakers. It's great to be with all of you today. My name is David Larson. I'm one of the physician directors in the Stanford Medicine Center for Improvement. And I'm delighted to be here moderating today's session. We're so glad to have you join us for the Stanford Medicine Center for Improvement lecture series. I'm going to introduce the topic and our speakers in just a moment. But before we do that, just a reminder that if you can have your camera on, that's helpful. We understand if you're eating, for example, if you like to close your camera for a few minutes so we don't see you chew, although we're happy to see you chew. That's okay too. But those who can turn the camera on, that's great. Please do mute until you have a question, and then you can come off mute, either raise your hand or just jump in when we get to that point. Please do write down your questions. I think the most, what we hear is the most enjoyable part, most fruitful part of these discussions often is the discussion that happens after. And so I know that if I don't write my questions down, sometimes I forget. So we encourage you to please write down your questions. Okay, and then Lisa reminds us that we're offering CME for this session, and those details will be forthcoming. Lisa, any other details before we dive in?
No, go right ahead.
Okay, great. Well, it's my pleasure to introduce our speakers and our topic. First, I would like to introduce Dr. Nicholas Madsen, who's joining us from UT Southwestern. Am I getting that right? Okay, just barely now, right? As I understand it. So Nicholas Madsen was recently an assistant professor of pediatric cardiology at Cincinnati Children's Medical Center, where he served for 9 years following completion of his residency and fellowship at Seattle Children's Hospital. As of yesterday, I believe, he began in his role as co-director of the Heart Center and the chief of cardiology within the pediatric group at UT Southwestern Medical Center. Dr. Madsen's clinical focus is in acute care cardiology and long-term outcomes for children born with congenital heart disease. And these interests motivated him to co-develop the collaborative that we're going to discuss with you, along with Elena Kipps, in 2014. Dr. Madsen earned his Bachelor of Science in Physiology from the University of California at Davis, where he graduated with honors, and earned his medical degree with honors at the University of Washington in 2005. Dr. Elena Kipps is from right here at Stanford at Lucille Packard Children's Hospital. She grew up locally here in Santa Cruz, completed her medical degree at Harvard, and after general pediatrics residency at Stanford, she completed a cardiology fellowship in pediatric cardiology at Boston Children's Hospital, and then practiced at UCSF until 2012, when she was recruited back to Stanford to become the medical director for acute care cardiology. And then in 2014, she co-developed the PAC network with Nicholas and continues to co-direct the program today. She's a graduate of the inaugural cohort of the Stanford Medicine Center for Improvement's Advanced Course in Improvement Science, or ACIS. We're very proud of that. Dr. Kipps and Dr. Madsen will be speaking to us today about their story of the Pediatric Acute Care Cardiology Collaborative. I'm not sure if it's PAC3 or PAC³, but they're going to tell us that in just a minute. And I think it's really going to illustrate the power of learning networks. And it's their hope that this collaborative will aid in the care of children hospitalized with cardiac conditions in regard to reducing complications, shortening hospital length of stay, decreasing the frequency of readmissions, and improving the patient and family experience. So with that, please join me in welcoming Drs. Kipps and Madsen.
Thank you so much, David. I'm going to share screen and I'll be navigating. I'll try to keep an eye on chat, as you so artfully did during our ACIS course, but it may be too much multitasking for one thing. We get slideshow.
We'll help you with that later. No problem.
All right, thank you. We'll play this from the start here. Yeah, thanks for having us and for that introduction. We're going to launch right back into it, so we can leave enough time for Q&A at the end and some nice discussion. So to kick us off, we just wanted to look back to sort of the old way of how translating new findings in the scientific bench world came into high evidence care to drive high quality care and patient experience. It was a more linear process. Insights were often poorly translated or poorly used or took forever. Patient experience really never looped back to informed the care and science. And then you put this model that might have worked in the realm of like big adult medicine with lots and lots of cases, but you try to translate this into pediatric illnesses, and specifically congenital heart disease with its heterogeneous populations and low numbers at any one center. It really will drive up that bottom rung of missed opportunities, waste, and patient harm. So a newer way was developed a number of years ago that's much more circular feedback model with these feedback loops are quite familiar to all of us in quality improvement science. And the vision of a learning health system really entails generating and using real-time knowledge to improve outcomes, engaging patients and families, as well as communities to achieve high-valued care. So we wanted to take that model, which could still be somewhat siloed, and really start to link together. So what if those learning health systems could link together hospital to hospital, sharing data as transparently as possible, sharing tools like quality improvement tools seamlessly, and linking areas of focus together in a harmonious way to be able to raise up the entire patient experience across the pediatric age spectrum. So Cardiac Networks United was built with this framework in mind, and helped link the various entities that had carved out niches within pediatric cardiology to look at both from a scientific and quality improvement way, and try to break down the silos, unite, and share data across that. And then you can learn also from the larger learning network that have even more years of experience raising the bar for kids with other types of illnesses. And we're going to get back to this in more detail later in the talk. First, we wanted to take a few years back look at what we founded together, the Pediatric Acute Care Cardiology Collaborative, and it is PAC3, not PAC³, although that would have been cute too. Basically, we came together, I met Nicholas for the first time at the American Heart Association meeting in November of 2014, and we started a discussion over lunch. And by the next AHA meeting in late 2015, we had 15 centers and representatives around a table to form our mission, vision, pick a name, and kick off the sharing and learning.
Yeah, thanks, Elena. From a shared appreciation for an opportunity of care and collaboration that didn't exist prior to that conversation, really sort of was the initial rooting of PAC3. And as you can see here, we were really focused on the problem of specific congenital heart lesion care and the fact that it's such a rare disease and that care is often variable and delivered in not only in various silos of hospital systems, but various silos within a hospital, one unit to the next and the like. And so we thought with our combined effort, we were out to improve cardiac acute care outcomes by fostering sustainable quality improvement initiatives and optimizing organizational partnerships as really our guiding vision, and really very specific in our attention towards quality improvement from the outset as a way of harmonizing a great deal of our work. And go ahead and go to the next slide, Elena.
Mm-hmm. It wants to, maybe. There we go.
And so what began with an innocent enough lunch, and I think, a good example of careful when you say yes to lunch sometimes, because it may lead to a lot of shared responsibility, has turned into something we think is truly terrific and only going to grow from here. And so at present, there are 41 member sites that are part of PAC3 with this focus on acute care within the pediatric cardiology landscape. And you can see the geographic representation there, including Toronto, so we can officially call ourselves an international learning collaborative. And what began as just a few sites getting together actually very rapidly evolved into the 41 that you see here. And as you might expect, all of us were worried in March of 2020 about a whole host of things. And Elena and I were worried, well, what would this mean for PAC3, and would we still be able to grow? And in fact, we've continued to partner with new sites, and the rate of that has not slowed down. In fact, it's only sped up. And I think some of that is due to the great utility of the collaborative itself, and the way in which we have returned the investments that people have made into outcomes that are desired. And we can go ahead and go to the next slide. So really, what are some of PAC3's highlights as we focus on this aspect of acute care cardiology, the in-hospital, non-ICU portion of pediatric and congenital cardiology? And at this time, what we are is the only national collaborative and registry with a focus on this particular aspect of care, or these encounters or episodes of care. We were very interested in setting up a registry, not as a sole purpose of our collaborative, but in an effort to have real-time data that could be benchmarked and compared. And you'll see some of that as Elena returns to the mic here in a few slides. And then again, as Elena mentioned, it's not enough to simply harmonize within the hospital or within the acute care cardiology settings. We really wanted to be collaborative and well networked within the larger fabric of pediatric cardiac care. And two such organizations, one with a particular focus on peds critical care and within the cardiac realm, which is PC4, as well as STS, which is the Society for Thoracic Surgery, which involves adult thoracic surgery as well. We really wanted to ensure that from the get-go, we saw ourselves well aligned with these two organizations. And so we've shared definitions and shared a lot of the mechanics of our organization very directly in an effort to not work alongside in parallel, but really to work together. And with that, we've upped our participation in national quality improvement and research initiatives. Again, in full partnership with these other collaboratives. You'll hear about a few specifics. We also think that quality improvement education is part of our mission, not only for the projects and initiatives that are sort of collaborative wide, but in order to provide a service to each member site of some tangible knowledge that they can take back to their local level, whether it's hospital or division or unit or patient specific, and then translate that knowledge into better outcomes, hopefully. And we've been very focused on all sorts of education, be it at the physician level, APP, bedside nurse, and certainly patient and family engagement as well. And then more recently, as you'll hear towards the close, as many organizations have done, we've taken a hard look at our own specific work and attention to inequities in the healthcare system and what that means within the acute care cardiology space. Go ahead and go to the next slide. So this is our organizational key driver. A lot to take in on a slide for sure. I think the reason we want to share this is for a couple of reasons. One, we think it's critical for any organization of this type to really root itself in this type of explanation of its work, where you can see our global aims and our strategic aims there on the left in the purple, as well as the what we are doing. What are these key drivers of our organization, and how are we doing that according to our interventions? You can see in the bottom left-hand corner, we've divided ourselves into various committees, and those committees slowly have grown over time and now even include a few subcommittees, but include things as attention to our database and education and outreach, patient and family action, quality improvement, and scientific review. And then really with a co-created focus on our key drivers, you can see them highlighted there with a little bit of expansion in the bulleted text. And then to the right, you can see the projects that inform that work and how that project workload is divided and where the responsibilities lie among our subcommittees. And with all of that, we hope to improve acute care cardiology outcomes and experience from the perspective of the patient, family, clinical, and hospital system. All right, next slide. But I think a distillation of all of that is really this Venn diagram here, which is where are we and where are we going? And we're very focused on collaboration, as you might expect, both within hospitals and across networks. We have quality improvement from the very outset called out as a real tool for us to lead improvement and to translate knowledge into improvement very rapidly. And then also some more traditional research using our registry and these data domains that we've created. But all of that is built around the structure of the acute care cardiology unit and the patients that reside in those units, and certainly the families, and the registry that helps to quantify some of that information in real time. Go ahead and go to the next slide.
So we wanted to give you a snapshot of how I might use this at a local level. So this is just one page. The blue shows Lucille Packard Children's Hospital, and the green is the PAC3 aggregate. And it's just showing one of the many pages that we have access to. So about encounter types and use of various therapies that may be quite linked to how acute of a patient can you treat on your acute care cardiology unit. So for example, we can see, just zooming in here, if you can see my cursor, milrinone, we have more kids on milrinone than the aggregate, and that really treats children with heart failure predominantly. We also have more kids on chronic hypertension, pulmonary hypertension medications, as well as treatment for arrhythmias. One I wanted to highlight today was the use of high flow nasal cannula. It is a direct result of our participation in PAC3 and being easily able to communicate to the 16 centers that had well-established practices to deliver high flow nasal cannula oxygen to their populations on their acute care wards, as well as all of the RN educational materials that is needed to safely onboard a group of 50 plus nurses to a new type of therapy such as this. So it was related to this that we were able to deploy high flow nasal cannula oxygen in February of 2019, and it's now in about 12% of our patients. It's in most of the transfers from the CVICU, and then within a few days, we typically can get them to regular cannula or down to room air. But it really helps drive flow through the heart center. Those children used to be stuck in the CVICU until they were completely off this type of therapy. Because of the success on our acute care unit, we were able to have this spread throughout acute care at Packard, and it is likewise enabled better flow from our PICU to our other acute care units. Another way we can look at the data within the site that harbors this is Arbormetrics is showing the performance at each center versus the other ones. So this is as it relates to unplanned care with acute care readmissions. And as clinical champion, I would easily be able to see which one of these bar graphs represents Stanford. And I would also have a key, and I could figure out which of these centers over here, which clearly have a lower readmission rate, their bar does not cross the average. And could I have a conversation with them to see how they go about this? What is their secret sauce if I wanted to start a new QI project on driving down readmissions at a local level? One of the central reasons we established PAC3 was to make it easy to share quality improvement across hospitals. At that very first meeting in 2015, I asked each center to bring one win and one ongoing opportunity / frustration to discuss. The overlap in the key projects was quite profound, and that was our first all teach, all learn session. Well before our registry was established and launched and all of the computer stuff that goes into that, now about 5 years ago, we sought out a way to unite and learn how to do network-wide improvement. That project was to lower chest tube duration in children having heart surgery, and we just concluded it in June. We are currently in the midst of launching our third major PAC3 project, which will get at improving discharge efficiency, efficacy, and the patient experience, as well as raise the bar and equity, so that, for example, kids whose parents speak predominantly Spanish are not stuck in the hospital longer than their English-speaking counterpoints. So we've worked with Cardiac Networks United to develop this 3 different paths to quality improvement. And I'll spend a bit of time today focused on our first successful PAC3 project, the chest tube reduction. So this is a slide I've shared, and many of us have shared at multiple meetings. The bar graph shows the 10 STS, which is at Societies for Thoracic Surgery, benchmark surgeries, which is, we wanted to do some apples to apples. And we started to look at chest tube durations across the 9 sites that rose their, volunteered to be in this initial cohort. And we discovered this orange bar dancing across the screen was quite a bit shorter in 9 of the 10 surgeries we were looking at. And so we sought out to discuss with that center, what is your secret? How do you get chest tubes out so much faster, sometimes on orders of magnitude faster than the rest of us? After that, we allowed each center to develop its own new method for removing chest tubes. We did not mandate a single bundle. We said, you have some liberty, but here is what works at this one center. And we discovered some other sites that were not involved in the pilot that did likewise, removing it predominantly on post-op day 1. And here is our results. So this is showing the X-bar chart for chest tube duration in hours, driving it from our baseline full year of data from mid to 2017 to mid 2018 of 89 hours. There was 4 of the 9 sites were really early adopters in this. And as soon as we discovered the model site and what their secret sauce has, started to change things. And then the rest started to come on board, and we drove it down at the end to about 66 hours. Similarly, perhaps not as drastically, since it's a lot goes into length of stay, we saw a reduction in postoperative length of stay for these 10 surgeries from 11.4 days to 10.4 days. And importantly, this is not just numbers on a screen and shaving off hours. It's truly impactful at the patient and family level. And here are some of the quotes we got from some of the families who participate in our Patient and Family Action Committee. Marielle is a Heart Center mom and our patient and family advocacy member for our Heart Center local improvement teams, and has done a ton of work over the years alongside me. And she really wished this had been live when her son Eli was last in the hospital, because it would have shortened his stay quite a bit. So I wanted to highlight very briefly, it was an honor, and I learned so much in the ACIS course this past, starting about a year ago and wrapping up this past spring. And I chose to focus on creating a change package to facilitate ongoing improvement at each center. We wanted to really capture the learnings of this first collaborative wide QI project and enable new sites to adopt and adapt our learnings to their own chest tube projects if they decided to tackle that. This is a real snapshot of the chest tube roadmap, kind of a nuts to bolts on how to lower chest tube duration, but also learn how to do quality improvement, because we found some of these sites, this was their first major QI project. And so this will link out to learnings from the collaborative, but also to IHI tools that are readily adapted, not just to chest tube, but many other projects. And Nicholas will bring us back into the learning collaboratives and networking.
Yeah, so stepping back a little moment now that you've had the introduction to our learning collaborative of PAC3 and where we've invested some of our time, we wanted to sort of set this within the larger field of pediatric and congenital cardiology. Go ahead and go to the next slide, Elena.
Mm-hmm.
And so as we're thinking about learning networks in general and what we mean by the term learning network, we think of as what's highlighted here: patients and families, clinicians and scientists working together to use data for clinical care, improvement, and research across multiple sites. The American Board of Pediatrics considers learning networks the best way to achieve population outcomes at scale. And networks are particularly important in pediatrics because of limitations posed by having small numbers of patients at any one site, and certainly the heterogeneity of a great number of the disease states that we care for. These networks involve collaborations among engaged patients and families, multidisciplinary teams of clinicians and staff, scientists and communities, and we've tried very much to reflect that within PAC3. Learning networks span a broad reach of conditions, settings, and geographic locations to drive the spread of evidence and innovation. So if you go to the next slide, what that looks like is really sort of something, obviously our theme is something circular, but really as we're thinking about this triad of patients, clinicians, and researchers, and how we can work together within the learning network framework to both learn and share, but really to improve and subsequently teach when we've identified opportunities for rapid improvement and improvement at scale. We think that there are necessary ingredients in establishing these learning networks, and you can see those highlighted by the numerical values there. So trusted and relevant resources, really a focus on natural engagement and ensuring that that natural engagement is founded on transparency and testing and implementing of those solutions. We think those solutions should be crowdsourced. There are certainly great examples of top-down approaches, but more and more we have a growing appreciation for what crowdsourcing solutions and even asking the questions, what that looks like. And certainly in PAC3, we're learning every day how to do that better and better, but we hold it up as a very important aim for us. And then, of course, the rapid dissemination, and this is what Elena highlighted with the Chess2 project. It is no use at all to end the work at the publication of a paper. And this is obviously sort of preaching to the choir, but it really establishing mechanisms where the gains that are realized through one testing or other scientific endeavor are then rapidly scaled and disseminated is critically important. And as we all know, it doesn't happen just because the paper is written or because the language or words are spoken at the podium. Sometimes the hardest part is actually figuring out how to move these new pillars of knowledge and better outcomes into the community. And so we think the learning network is a terrific way of doing exactly that. Go ahead and go to the next slide. So we mentioned PAC3, the collaborative and learning network that we've been a part of, but like all circles, you can get broader still. And so we've talked a little bit about Cardiac Networks United, which really is a coming together of many collaboratives and learning networks within pediatric cardiology. There's those that are focused on certain types of cardiac conditions, be that the National Pediatric Cardiology Quality Improvement Collaborative, NPC-QIC, which focuses on single ventricle patients. There are those that are focused on heart failure, and in particular ventricular assist devices, which is the ACTION network. We see others still that are focused on other episodes of care, such as critical care and cardiac critical care to be specific, which is PC4, and then a number of others that are focused again on Fontans or neurodevelopmental outcomes, all of which have decided that they will form this umbrella network called Cardiac Networks United in order to more rapidly translate shared knowledge. Go ahead and go to the next slide. So,
okay, so here's how we test Elena's ability to do this. So 1 second, stop share and then reshare this one. And then I'm going to, I think I have to start more. And share computer sound. Okay, this should work. Let's do this and then make it big.
A growing community that helps millions of people and improves everything from health outcomes and everyday quality of life for patients, their families, and research discoveries. How do we get the best help for a little girl with a chronic condition? How do we get the best help to all patients? We do it together, healthier together. Learning health networks were named one of the top innovations in the past 25 years and have won some of the country's most prestigious awards for social innovation, quality, and safety. This is a revolutionary leap for healthcare, connecting the science of modern medicine with the wisdom and care of a community.
Okay, I think that might have been abbreviated, but c'est la vie. Let me stop share and then go back to our slides, which are these. And play from current slide, but easily found a 3-minute video on YouTube. Let me advance. Back to you, Nicholas.
So when we think about the learning network, we think it's in particularly important to assess the maturity and the qualities of the learning network itself. And so there's actually a grid to do exactly that. This is the learning network maturity grid that you see before you. And it really splits a learning network into 6 domains: systems of leadership, governance and management, quality improvement, engagement and community building, data analytics, and research. And it then allows you to examine a learning network across these various domains to see your degree of maturity. Because not only are we focused on the improvement that our patients experience, but we are equal parts turning that lens in towards the learning network itself and thinking, where are we going? Where are we more or less successful? And if you go to the next slide, you can see where PAC3 lands at the moment. So, you know, sort of the circles, or not quite circles, but as you move outwards across the ripples, you become a more mature organization. And you can see that we are most mature around quality improvement, but continue to see greater opportunities within our research endeavors. And so this allows this tool, which is a survey tool that you distribute across your network, where people are answering a number of questions, and it allows you to score your level of maturation, and is meant to be done over time. And the assumption is not that you're 5s all across the board, but rather that you are working on various avenues in order to grow your organization. And we found this to be a very useful tool of self-reflection and of identifying opportunities for improvement. And so, as we have shared a little bit about our network, we want to show a little bit more about these other networks that we mentioned, just to give you a sense of the true impact and scope of the work. And if you go to the next slide.
Oops.
Sorry. This is the NPC-QIC collaborative, focused on single ventricle patients, in particular from birth to 1, and subsequently they've begun to focus on birth and even pre-fetal care until the Fontan circulation that these patients will eventually have as part of their care paradigm. But as many of you may be aware, there's a great deal of mortality risk within this vulnerable population. And so NPC-QIC, as one of its primary goals, has looked to address mortality. And this data is from a few years ago, and it has actually continued to demonstrate its utility in addressing something as important and as difficult to modify as mortality. And this has been a real hallmark of this organization's success, and obviously lends credence to the mechanisms behind the learning network paradigm. Next slide. This is ACTION, which is particularly focused on advanced heart failure therapeutics, including ventricular assist devices. Ventricular assist devices are associated with stroke outcomes, and you can see historically, going back to 2014, stroke outcomes that are approximating 30% of patients. And you can see through the action of the ACTION network that those stroke outcomes are much less frequent and are now down into the 12.5% range. And then lastly, PC4, which I introduced earlier, has a focus on cardiac critical care. They've, in the recent years, been focused on cardiac arrest prevention. And you would think, well, shouldn't they have been focused on this all along, or haven't we been trying to prevent cardiac arrest all along? Well, we certainly have. But in many avenues, cardiac arrest prevention in the cardiac ICU was sort of like discussing CLABSIs in in 2007, where people thought, well, I know it's recommended that we want to lower them, but it's impossible. Clearly, that's not the case, and clearly here, PC4, an organization focused exactly on these vulnerable patients with high risk of cardiac arrest. They have, through very simple tools, meaning simple tools of bundles and utilizing information that is already available, but simply organizing and disseminating and limiting variability, you can see that they've made terrific inroads in terms of the event rate within these populations. And so, you know, we have over time really further invested ourselves in these learning networks, and Elena will share a more recent example that affects all of us day to day.
Thanks, Nicholas. Yeah, we wanted to wrap up today just showing how we can work outside of even Cardiac Networks United and lend a hand to one another by working across these pediatric learning networks. So there's an entity called the Learning Network Collaborative Conference that once upon a time was held twice a year only in Cincinnati, and difficult for most people to get there. But with COVID and Zoom, it's really opened the doors to many more people from across the country being able to learn from all these networks. So I've been fortunate to have attended the last two. The last one was held in June and really focused on how to accelerate our diversity, equity, and inclusion work. So these, all these centers, their icons on the board here, came together, and most developed a presentation about what their learning network equity journey has been to date. They looked back, they looked ahead, they called out their own barriers. We all broke out into these 5 rooms here. You can see the shorthand names of all these various networks. And then as an example, I just took 2 of the slides that PAC3 gave to their breakout room. We highlighted the key driver diagram revisions that we made with equity in mind. I've highlighted the ones we specifically called out, wanting to achieve an inclusive culture, wanting to recruit diverse patients and families to lend a hand. And the rest as highlighted here. And our slide to call out our current barriers and roadblocks was the feeling of very high level of interest across the 41 centers, but a fairly low feeling of expertise amongst the current membership. We also felt constrained about how the registry was currently set up, and feeling an inability to capture the social determinants of health to help get at measuring the inequities to then help solve those. So we asked the people in our breakout room, how have you recruited members with health equity expertise, and how have you prioritized next steps? This is an important thing, but all of those aspects to the maturity grid that Nicholas mentioned a few slides ago also feel like pressing matters. And so all of those groups discussed, and the feedback using statements that really engender a nice discussion of I like, I wish, I wonder. And we came up with kind of draft what's next statements and shared those out. And then we came all back together to share the steps we'd taken and the ones we plan to take in the next year. So these aha moments, to borrow a term that David Larson liked to use during ACIS, regardless of where each of us personally, where each of our collaboratives were in the equity journey, we really felt like we took away some next concrete steps that we could start to take. And we also knew, oh, such and such registry is doing it this way, or they have this tool to recruit families that really sounded intriguing and applicable. And so we can continue the conversation past the conference. So I just wanted to close today in saying that the way the improvement has reached the patient bedside has really been transformed from that plodding, wasteful, linear mechanism into a much more feedback circular mechanism. by incorporating the patient voice in co-discovery and co-design of care solutions and helping drive the priorities that our scientific bench research colleagues can go after. Learning networks are primed to be the primary engine to transform pediatric cardiology care outcomes and the patient family experience. We've been able to highlight today the network-wide projects that lowered chest tube duration, as well as length of stay, lowered mortality for single ventricle patients, achieving fewer strokes in heart failure patients awaiting their transplant with a VAD, and even lowering cardiac arrests in the ICU, work that has been done by various colleagues in the last several years. The foundational aspects of learning networks are very well described now, as well as their maturational network or framework, and the steps that we can take to maximize our own potential. So sharing on this, on the grand scale in this Learning Networks Collaborative Conference, really we felt best enabled us to respond in a more time-sensitive way to rise up and make real progress to the challenges of making healthcare equitable. And with that, we wanted to close our presentation and open it up for questions. And I haven't been able to even see chat, so I'm going to go escape. Now I can see people better.
Well, thank you so much, Elena and Nicholas. This is really fantastic, very interesting. I have a lot of questions. Not a lot of questions have come in chat yet. Hopefully there are lots of other questions out there, but if not, then rest assured, I'll be sure to pepper you with questions. No one else does. So I'm going to pause though before I weigh in and ask for anyone who'd like to come forward with questions. Okay, as people
I had a question, David. I put it in chat, but for Dr. Madsen or Elena, thanks so much for a wonderful presentation. It's so nice, Dr. Madsen, to have you as well. How often did you all meet as a collaborative? And then how often did you intersect with that larger collaborative? Just wondering about time commitment.
Yeah, it's a good question. We certainly find that the more often we meet, the more work we get done. And so there is certainly some wanting to balance that among all of our commitments. And so we've been pretty focused on a fairly organized approach to our meetings, be they within the subcommittees that I highlighted earlier versus some of the working groups. One of the things that I would advise, and I'm sure Elena would echo, we have an unbelievably talented program manager who organizes PAC3. If it were not for her name is Margaret Grappe, if it was not for her, to have some of the clinician leads be the rate limiting step of the organization is like trying to sail with multiple anchors. And so, you know, we really would recommend finding a way, if one is interested in sort of beginning this kind of journey, is ensuring that you take careful stock of what you're good at and also what you're not so good at. And for Elena and I think fair to say that that kind of organizational structure and keeping all the wheels aligned is challenging. And so it's been critically important for us. So I think, and you know, to answer your question more directly, we do spend a lot of time on this. I mean, there's, you know, in Elena and I leading this, we meet, you know, at least weekly among our executive team to ensure that we're moving things forward and we're coordinating. Those who are participating at various centers don't have that degree of commitment, but as you might expect, you know, the only way to move the needle is certainly with you know, constant attention to the details.
Yeah, and Lisa, I think our committees typically meet at least 4 times a year, perhaps a bit, maybe an extra little working group session to prepare for our 2 annual meetings, which typically pre-COVID were in person, often one in Ann Arbor to combine with our PC4 colleagues. where we would invite not just clinical champions and nurses and APPs, but the data managers who collect all this data to make sure that they felt that they had a home and were driving the improvement to creating a successful and sustainable registry mechanism. And then the spring conference typically has been a PAC3 only affair. And the learning network, the larger meeting is also twice a year. I think that's been the case for the last several years.
Thank you.
So a question came from Bob Turbo, and I think he's revealing himself as a specialist here because he's asking about the early outcome of a Blaylock-Taussig shunt versus a Sano. Maybe Bob, if you want to, further explain your question, and then maybe in a larger context for how, maybe more broadly applicable.
Hi, is the microphone working?
Yep, sounds great.
Hi everyone. Thanks, David. So once again, I'm a neo, so please use small words and speak slowly if you're a cardiologist, and don't speak over my head. But is the collaborative something that would be amenable, or is it too granular of a question if you wanted to look at early Norwood, the clotting off of the Sano shunt? Is this the type of research modality where you could actually give feedback to the bedside clinicians why you might want to proceed a child with certain single ventricular anatomy, why you would want to go one direction and not the other?
Yeah, thanks for your question. Bob. Interestingly enough, that has been a long-term question of pediatric cardiology, as you know, and so there's been a number of organizations that have looked at it, in particular the one we highlighted earlier, NPC-QIC, as well as a NIH-sponsored network within pediatric cardiology called Pediatric Heart Network. And so while that question itself has been addressed quite formally between those two organizations, not to the great reveal we all hoped in terms of offering the solution that, if this, always this, if that, always the other. But it has certainly highlighted a few areas of real separation and of true knowledge. But it is a great example. The question itself is a great example of something that you can much more readily address through the mechanisms of these learning networks than you could if you were a single center who was trying to answer that question, or even if you were 3 or 4 centers. If all the major centers in California decided, oh, we're going to address this question, it would still be a tremendous struggle. And you really have to look at expanding it across a much broader range. But that has been possible, and the way that you could address that type of question and the way it's been done is you have your registry within your learning network, which is not so granular that it could answer exactly that question. But then as the network decides, this is the question that we think is most important, we want to invest more energy, you then build an additional module that essentially runs in parallel and is completely interwoven with the registry, so that you ask these additional 12 questions of these additional, patients of interest, and then you bring in the 400 other data variables that the registry is already collecting. And then over time, you can potentially address that question more fully. And so really the learning network forms the scaffolding or the backbone to which you can then address very specific questions to hopefully great success. And so that hasn't happened for your particular question within PAC3, but it has certainly happened within these other organizations. And while we haven't come to some new revelation of perfect knowledge, it has certainly helped us understand which patients do benefit under which conditions.
So thank you for that. It brings me to a question that it kind of addresses to some degree what Joy is asking in the chat. Can you say a little bit more about the balance between really kind of learning locally and then sharing globally? So you test and improve and then you share and spread, versus designing the bigger test from the outset so that you're all learning together, or maybe one happens more in the earliest stages and the other happens more in the later stages. Maybe walk us through a little bit more of that kind of, local versus kind of global learning in a learning network.
Sure, I'll I'll try to get at that. So with respect to how we designed the chest tube project, the earlier than launching even the pre-data for that full year, we did a survey of the centers to try to get at, do you even have a standardized approach to removing chest tubes? Found quite a bit of variability in whether they have a standard or not, and if that standard, what that standard was, and which patient population. So we thought it would be quite an uphill battle to say, you know, the model center removes tubes on post-op day 1. But, you know, Michigan's been taking them out after 2 days of having like less than a minuscule amount of output from each individual chest tube. It just, the cultural shift would have been too great to force that upon them. I think their surgeons, their ICU, their acute care cardiologists would have just completely rejected the project. Instead of that, said, hey, this is what this one center is doing. This is why, and here's their reinsertion rate. Here, you know, here's their balancing measures. It doesn't seem to be greater than anyone else's. What would you like to do? What feels right to you now? And then can you iterate on that? And I think they were able, you know, Michigan specifically, to just pick on one early adopter site, really went after this much more aggressively than I thought they ever would have been able to, because they chose how to do it. They decided that they would take this approach of taking them out on post-op day 2. For some reason, that seemed doable, and a bunch of their advanced practice providers and nurses really got on board and helped usher it along, and build out those Pareto charts to figure out what were their barriers if they weren't following their like new mantra. So I think that starts to answer that. We sort of go both ways and have it more fluid. It certainly feels more, I don't know, organic than what I saw kind of as an outsider to when you know, the Ohio SBS was first launched at PAC3, and these very specific bundles that you sort of need. The mandate was follow this for CLABSI and follow this for the other hacks. And that certainly has been extremely successful in driving down hospital-acquired conditions for our pediatric patients, you know, locally and across the board. But we felt it prudent, at least as we are newly approaching this on a collaborative wide level, to do it a bit more choose your own way, and then tell us what that is. And then we've been able to iterate. So for example, our registry is going to version 1.5 and will enable the collection of this chest tube data sort of automatically by our data managers instead of by yours truly at PAC3. And we're going to continue to push the envelope. I've re-met with the surgeons, re-met with the ICU, and we're going to be able to shave off probably another 30–50% of the chest tube time. But it's, you know, it's been a process. It wasn't just like we're going to do it post-op day 1 like this one site. Nicholas, do you want to expand on?
Yeah, I think
that from David's bigger question.
At risk of being too philosophical in addressing your question, you know, I think that trust and the development of trust is really critical in managing this type of learning network. And in order, this is just my opinion, so again, apologies, but in order to manage that trust, I think it's really important that there is this sort of bidirectionality, that there are times where we coalesce around a central question. And in order to drive that central question, there's a little bit more of maybe the experts or top-down approach, but there's a receptivity to that because that is not the exclusive manner in which we operate, and that we do a lot of the all teach, all learn, all sharing, stealing, you know, shamelessly from each other. And there are equal parts times when ideas come from that sort of that more grassroots level and then make their way into larger projects. And so I think that kind of bidirectionality where all stakeholders are engaged and involved and builds that type of that overall trust within the network that then allows for there to be times when, you know, this is decided as a central feature of the network, and we're going to all invest time in this project, not just for today or next week, but really for 2 years or whatever the case may be. And I think, you know, that notion of trust is is so critical, and obviously a lot of the work we do day to day, and that is really dependent on the nature of the community that you're building within your network, and holding that as a central pillar of attention. I think it's not on that maturity grid that we shared earlier, but it very easily could be. I mean, you could easily just, if there was a good measure of trust, you could easily utilize that, and that probably would be a great surrogate for a lot of those other measures.
Great, thank you. Other questions? Okay, that probably wasn't 10 seconds. I'm told I got to wait 10 seconds. It's really difficult for me. Then I do have one question. Maybe we may end up wrapping up on this. We often talk about, in our advanced course, we talk about learning networks, just the general concept. And I'd love to get your thoughts on to what degree does the concept apply, locally? You talked about how you've got a network of networks, right? So you went kind of one layer above, but what about now kind of thinking in your local institution, either formally around or informally around this specific concept, or just in general, the same, a similar approach where you take, autonomous teams or autonomous groups, they get together, they innovate, they share with each other and learn. So I'd love to hear your thoughts on how well that scales down as well as scaling up.
Well, I'll give my local impression, and I'd love to hear what Nicholas has to say about his former institution and how they do that. I have dreamed of having cardiac networks united at the local level. I think COVID got in the way of a few things on my list, and that is one of them, to make sure that we are all aware of the MPC-QIC data that we collect. Of the newest one that we're really trying to get after is the cardiac network neurodevelopmental outcomes, because we're launching a cardiac neurodevelopmental clinic imminently. I think there is a degree of silos within the division of cardiology and the PAC3 Heart Center that are quite bridgeable, but haven't been bridged quite yet, to maximize our use of all this data that we spend quite a bit of money trying to maintain and collect and then pass audits for. We do have an element of that. So I run the acute care local improvement team, and for many years we've had at least one meeting a month with our cardiac ICU colleagues, that making sure that anything that they deploy there with respect to CLABSI prevention or family intervention, to make sure that we're addressing their emotional needs, is translated, so it doesn't just cut off at the time of transfer. So that'd be quite unfair to them, and their innovations really should translate nicely and back and forth. So we've tried, at least on that meso level, to make sure that things are deployed across the Heart Center and discussed, so they're not only appreciated in one part or the other, but I think there is still opportunity there.
Yeah, David, I think it translates really favorably, as long as there are those who are willing to do the bridge construction. It's so much of what this Cardiac Networks United organization has been about unifying data definitions and ensuring that if you say pleural effusion to one person, they know exactly what that means, and you all sort of define it the same. And so given the investment in those shared approaches, it really does translate very nicely. I think it is up to us as members of those teams to ensure that that is what is happening. It is so much easier to have a meeting with 4 people rather than 14 people. And so a lot of us then just continue to have our 4-person gatherings. But it really is critical in terms of advancing new knowledge and ensuring that we're not trying to work on opposite sides of a wheel, but really are sort of partnered from the start. And so I think that the construct is there, and it's very intentional. Some of it is overcoming some local inertia, and that can be a challenge, but I think it's certainly very doable. And I think it's worked well in Cincinnati, and certainly, I think we could spread that very well.
Well, thank you very much. I want to say thank you to our speakers. Nicholas, thank you for joining us while you may be in your hotel room. I don't know, but Yeah, they're newly relocated to Dallas, so thank you so much, Elena. It's a delight to hear all the great work that we've heard about and hear it in more detail. Everyone who's on, if you could please come off of mute and join us in giving our speakers a round of applause.
Thank you. Thanks for having us.
I'm sorry it's so anemic. There's much more behind it than what you're hearing.
That's right.
Thank you again.
I
And
can
thank you
imagine
all.
the roaring.
That's right, there's a roaring applause. Thank you all for joining
All right,
us.
thanks everybody. Have a good
Wonderful day.
afternoon. Bye.
Bye.